I'm very excited today to welcome Dr. Newman-Casey, who is, among other things, many other things, a good friend and collaborator of ours at CHEPS. She's a clinical ophthalmologist specializing in medical and surgical management of glaucoma. She's an assistant professor of ophthalmology and visual sciences, University of Michigan Kellogg Eye Center, completed medical school residency and fellowship here at U of M, and holds a master's degree in health services research as well. Her current research is on developing and testing technology-based behavioral interventions to improve glaucoma self-management support. She's also interested in how operations engineering techniques can be used to improve patients' experiences in clinic and identify ways to integrate more education into patients' clinical encounters. And she's here to talk about this research today. Thank you, Paula, and welcome.
So thank you for the kind introduction, and thank you for having me today. I have been enjoying working with CHEPS for the last, I think it's getting on 3 or 4 years now on this project. So we finally have some really exciting data to share. So now I'm coming to your seminar series, an excited person. So this is kind of how do we use operations engineering techniques to improve the patient's experience in clinic. So what's the problem? If you look up Kellogg Eye Sensor on the internet, it will tell you what the problem is. So one of the problems is that you can see the office doesn't value your time. After a 3-hour drive to their location, I was left waiting in the waiting room for over 2 hours and I gave up and left. I mean, obviously this isn't everyone's patient experience, but if you look us up on the internet, you don't want to see like the 1-star reviews. This is a 1-star review. So we're not valuing people's time. And I think that this is, while this may seem a bit extreme, I don't think it's crazy. I think people have a really long wait time in our clinic. There's a lot of waiting, there's a lot of things they need to do before they can see the physician. And so this is definitely a big deal for patient satisfaction and for getting people to come back for their appointments, which is really important. So, maybe hope it won't start right away because I want to just tell you a little bit of background information about glaucoma and why it's so important for patients to come back all the time for their follow-up visits. So this video will give you a little bit of an overview of what glaucoma is and how it's a lifelong condition that really requires people to get control of it by coming back for their appointments, taking their medications, and if they don't, they will lose their vision. But it's a very, very, very kind of silently, they call it the thief in the night, because it just goes so slowly for so many years. People don't know anything is wrong until it's almost too late to help them. You don't want people to have symptoms. So we're trying to get people to come back for an asymptomatic disease, at least to them. We're giving them medications that cause side effects and cost money, and we're asking them to wait in clinic for hours to see us, to get those prescriptions and to get our advice. So wait time becomes a big barrier to people really participating in their care. So this is just a little bit about glaucoma.
Primary open-angle glaucoma is the most common form of glaucoma. Over time, the brain of the eye stops working very well. This leads to a gradual increase in eye pressure. Eye pressure slowly damages the optic nerve. The optic nerve acts like the electricity cable that connects the eye to the brain. When it is damaged, it can no longer bring strong vision signals to the brain. This leads to very slow vision loss without causing any pain. Your side vision is affected first. Your central vision, the vision you use to drive and read, is only affected when the disease is extremely severe. Often, you are not even aware of the trouble the eye pressure has caused until the optic nerve is already badly damaged. Your doctor will recommend treatments for your glaucoma to keep your eye pressure in a safe zone. Keeping your eye pressure in this safe zone will stop more damage from occurring to your optic nerve. You should ask your doctor what a safe eye pressure is for your eye.
So I'm sorry that was quiet, but you get the gist. Basically, people don't have symptoms and we're asking them to engage in treatment. Yeah, go ahead.
What's the fluid that builds up?
It's called aqueous humor. Yeah, so your eye is continuously producing fluid so that it stays round and it isn't like a raisin instead of a grape. You need that fluid to be produced, but you also need it to drain because it's continuously produced, so it needs to continuously drain. Otherwise, the pressure can build up in the eye if you have poor drainage, and it can cause damage to the optic nerve, which then limits the vision signals that can be sent to the brain. Yeah, good question. Please interrupt with questions. So, now, I took a course because I thought, man, how can we make this better? And I took a course called Lean, and they were like, you need to be able to measure something if you want to make it better. I was like, okay, we got to figure out how we can measure wait times if we want to make them better. Because if we're not measuring them, we're not going to know if anything we do is any better. Because most of the time as clinicians, I'll tell you what we do. We're like, oh man, today was terrible. What did we do? Like, Mrs. Jones was so mad she left. Like, what can we do to make it better next time? So we sit there and we're like, well, maybe we should, have the return visit come before the new patient visit. We're like, oh, maybe we should, and we're kind of like, maybe we shouldn't, and making changes to the schedule, but we don't have really a way to know if we made a difference. So I thought, okay, we got to get granular. So first thing we did was just a regular kind of A3 paper version. Let's take a stopwatch to clinic and start trying to quantify how long are people waiting, how long are people actually being seen by healthcare providers during their appointment. And because hanging around with a stopwatch takes a really long time, it took one medical student the whole summer to basically follow about, I think we had about 70 patients. So we were able to gather, we had a couple more than this by the time things were over, and we found that on average our new patients and our return visits, our new patients were about 3 hours, our return visits were about 2 hours, and the new patients, they were being serviced about half the time. They were doing testing, they were seeing different providers, so they were kind of, they had less to complain about. On the other hand, return visits, they were in the clinic for a shorter amount of time. They were there for about 2 hours, but 2/3 of the time was spent waiting because they didn't need as much when they came back for a return visit, and they were oftentimes getting stuck behind a new patient visit and then causing them to have a longer wait time. So we brought this back to our glaucoma clinical team, and we sat around and kind of thought, well, what is going on in clinic? Like, we did a root cause analysis. And we kind of walked through all the different scenarios of why do patients end up waiting so long in clinic, especially the return visits. Why do they end up waiting so long? And at the end of our conversation, we involved the schedulers, we involved our lead technician, our clinic manager, we have like an air traffic control person, who sits like in the front of clinic and kind of says, oh my goodness, go see that person next, go see that person next. We involved kind of everybody, and I brought it also to all of our faculty. And that's what we came up with, was that our templates were just not working together well. So we found that, yeah. Oh, yes, okay. So a template in my mind, and you can correct me if I'm wrong, is basically, it's an Excel document that says how many slots for different appointment types each provider has for a given day. So one thing in our clinic was that we have 12 providers, and there's not a master schedule. So we have 12 providers who all have kind of their schedule tailored according to their needs. So like I would say, well, I want to see 30 patients, and I want to see 4 new patients, and I want them in this order, and I want 10 visual fields, and I want them in this order, and I want so many post-ops, and everyone was kind of operating in a vacuum. So even though we all share resources like technicians and ancillary testing equipment, we didn't have one giant document that said, this is how many new patients are showing up at 8 o'clock. This is how many visual field patients are showing up at 8 o'clock. When we put that all together, we found that sometimes we were really missing things. Like we would schedule, there's only 3 people who can do visual fields, and yet we were scheduling 5 of them all at once when you looked at all the providers who were using the same clinic resources at the same time. So scheduling and then the subsequent batching of patients, which was a new term for me, you guys are probably very familiar with it. So basically, there's nobody ready for me when I walk in the door at 8 o'clock. And then I have, 2 patients in visual field, 1 person getting worked up by the technician, and then all of a sudden at 8:45 I have 3 patients ready for me at the same time. And then the poor person who I see last is now gonna have waited, if they all had 8 or 8:15 appointments, is now gonna have waited for me to see those first 2 people, giving them a really long wait time. So we also kind of talked about how having unscheduled ancillary testing was another problem. So it all came down to this scheduling thing, like things weren't being scheduled well. It felt like we were going through waves where everybody was crazy busy and then times when nobody was busy at all. So we thought, all right, we gotta really work on this scheduling piece, but in order to inform a better schedule, we need better data. We need to know how long does a new patient appointment take? How long does a return visit appointment take? How long do patients spend with each of the providers? How long does a visual field test, our ancillary test to measure people's side vision that we do on lots of our patients, how long does that take? So that's when we got Amy involved. And we said, we need some help to design a low-cost system where we can basically, where we can quantify the amount of time providers are spending with patients and the amount of time that patients are spending waiting in our clinic after each process step. And we need to do this in order to enable continuous quality improvement so that if we make a change, then we can measure it. So we wanted something that was low cost because I had to be able to do it with an M-cubed grant and portable to potentially be able to transfer it to other clinics and also scalable in case we wanted to use it in more than just our clinic. The other primary objective I had was making it easy. So as a clinician, I don't want to be running around with a stopwatch. I got enough to think about when I have to go see like all the patients and everybody's always mad at me because I'm always late. Like I can't also remember for some reason to like hit on and off on a stopwatch. And when we ask the technicians and the nurses to do that, they oftentimes feel like we're big brothering them, like we're gonna be mad at them if they take extra time with a patient. So I had to frame this very carefully to the staff, and I wanted to say, I don't mind when you take extra time with a patient. I'm really trying to find out how long patients are spending not seeing anybody. That's what I want to know. I want to know, because patients aren't mad when you take 5 extra minutes with them. They're mad when they're sitting there and nobody's paying any attention to them. So that's kind of how we brought everybody in, and I also wanted to make it really easy. So basically, we all just wear ID tags. So this is what brings me to radio frequency identification. So this is a huge industry that's used by Amazon and Walmart, really pioneered by Walmart, in tracking packages. This is how they got their supply chain to be so awesome, is because they were one of the first businesses to use radio frequency identifying technology to track all their inventory all over the world. So they can tell you where their boxes are, you know, in their supply chain everywhere. And so we were thinking, you know, Walmart did it. Like, how come healthcare system can't track people the way that Walmart and Amazon can track boxes? And I'll tell you, there's probably a few reasons why we don't, but there's a few reasons why it's an interesting idea. So, a little bit more about RFID, radio frequency identifying technology. It has to have 3 chunks. It has a reader, a tag, and then middleware. So the tag is essentially, it's, you know, just like your UMID, I think probably has an RFID in it so that you can swipe on the door and it knows it's you. It's a tiny little computer chip that's not too smart and that just gets excited whenever it sees an RFID reader with enough energy to send a ping back to the reader and to say, hello, here I am. So all it does, because I had the technicians and the people in clinic were like, so are you gonna steal my credit card information? Are you gonna like watch me when I do all these things? And I said, no, it's not. I mean, it's true that that is used in credit cards, but the purpose of this system and what it's set up to do is pretty simple. All it does is every time you walk next to a reader, it pings it and says, hello, I'm here, and it time and date stamps it so that we know which room you were in based on which reader you pinged and when you were there and how long you were there for. We also know who you were there with by cross-matching the data. So we want to know, who were you in the room with? Were you there by yourself? So was the patient sitting there by themselves, or were they with a provider? So we have these readers installed in the exam rooms. Patients and providers are wearing tags. Yep.
So you can cross data, we need the provider also has an RFID as well.
Right, so all the providers wear tags, and that's constantly pinging. So it says, Dr. Newman-Casey's in exam room 6, and it's July 16th, and it's 3:40 p.m., and that data is constantly going to the database every half second when I'm in exam room 6 or when I'm in any exam room that it has an RFID reader in it. So then there's this piece of middleware, which is how the information from the hardware, from the RFID machine, actually gets put into a database. That required some custom programming. But before we get to the middleware, we would like to just go through, there's different categories of RFID tags, and we got to pick a passive tag. And the reason that we picked a passive tag was because it's cheap. So there's two main categories of RFID tags. The active tags have a battery, and they are usually big, kind of like those flying saucers at the restaurants that you know say that you could come back in now. They're expensive and bulky. So they were, when I got a quote, they told me it would be about $100 a piece for these active RFID readers, and then people would be expected to carry them around with them. And I thought to myself, my goodness, I have no desire to carry a giant flying saucer with me all over clinic, along with like my pens, my paper, my lenses, it's like too much stuff, right? It's already falling out of my pockets. And then I thought, and what are the patients gonna do with them? They're gonna like put them in their purse by accident, they're gonna leave them in the bathroom, and they're $100 each. Then what would happen? So I really wanted to focus on, could I find super cheap tags that would work in our clinical environment? And so we found that you could use these ultra high frequency passive tags, and they had a strong enough signal. So the reason people sometimes choose the active ones is because they can read over a longer distance. But clinic isn't that huge. So we were looking at these ultra high frequency passive ones that would let us read over a longer distance, but still be really cheap and be like something that you could wear around your neck on a lanyard. So that was the reason we chose these passive ultra high frequency RFID tags, and they cost between 14 cents and $1 a piece. So if somebody walked away with one, oh well, right? I don't have to like worry about calling them at home and asking them to send me a self-addressed envelope and send them back. Yeah, so this was just our cost estimate that would say that we would save $14,800 if we chose to use the passive RFID tags instead of the active RFID tags. And then we also looked at, we're really cheap. So basically we're thinking, do we want to use these reusable passive RFID tags that cost 14 cents a piece? Well, we've got 11,000 patient visits a year. If we have to pay 14 cents every time somebody comes in, that actually ends up being kind of a lot of money. Whereas if we can reuse the tag, we save a lot of money because we're only going to spend $200 or so a year. Even if we lost 10% of them, it wouldn't be so bad. So you can see that at 14 cents a piece, we would need about $1,500 worth of tags per year. Whereas if we use the reusable ones, we would only spend $240 a year. So being my cheap self, I decided to go with the reusable ones. And that meant that we had to also figure out how to write and rewrite them. We'll come to that in a minute. So then we went to, well, what RFID reader is best? And again, it came down to cost. So we picked this ThingMagic Astra EX reader that cost about $1,200 a piece because it had multiple connectivity options. We could connect over Ethernet or Wi-Fi, so it's portable, and it also had an integrated antenna, and that actually became the most important thing. There are many other RFID readers on the market, and many of them you actually have to wire into your system. And we got estimates, and every time we would want to wire one into the system, it would cost us $1,500. So we said, let's get the wireless kind that we can plug into the wall, get power over Ethernet, and be done with it. So even though it had a more expensive upfront cost because you don't have to pay for integrating it into the ceiling, it became much cheaper. Then we got to this issue of middleware. So the system is meant to be used in a Walmart warehouse where you have one on the indoor and one on the outdoor. It's not really meant to be used in a clinic in 26 rooms, all very close to each other, where they're all open at the same time. So when we tried to use their off-the-shelf software, it kind of freaked out and it wouldn't let us open multiple windows at the same time and receive data from all 26 at the same time. So we ended up having to make our own custom middleware, and that was HITS, the Health Information Technology Services. They actually made a piece of software that allowed us to remotely manage all of the different RFID readers and also receive data from all of those different readers simultaneously. So this is kind of the schematic. People come in, I think there's a, okay. So basically, people come into clinic and they get a tag. And the tag is written using something that looks like the scanner from, Myers. And that puts a unique identifier, which is the person's visit number. It's called their CSN onto the tag along with the time and date stamp of when they're coming in. And then when we get the next person coming in, we rewrite it. So it writes over the other person's thing so that we're not keeping the old person's data on the tag. This is what the reader looks like in the clinic room. It's just on the wall, it's pretty unobtrusive. And then this is a schematic of how many, we basically installed them in every single place that a patient or a provider could go. And then this is a schematic of how the data then gets transferred from the tag. And because it's protected health information, it goes into a PHI protected database from HITS. And then we're also getting a second data stream from the electronic health record so that we can understand what are patient characteristics or visit characteristics that might confer additional wait times or additional process times. So, for example, we'd want to know, is a new patient going to be different from a return visit? Is an urgent visit different? And then maybe, is somebody who needs more testing going to have longer wait times? So we have all that information coming from the electronic health record and being merged with the data gathered from the RFID based on people's clinic visit number. That data, so our database would fill up because the RFID machines sample it twice per second. So our database would fill up, except that we have Trevor and our CHEPS glaucoma team archiving all the data on a weekly basis, cleaning it out from the server, and zipping it and putting it away in a neat little package in our database, so that we cannot gum up the works and continue collecting data. So, and this is just, so we basically, because we were worried about collecting the amount of data that we would be collecting from these RFID machines, you can sample at a much higher frequency than twice per second. So we tested, would we be able to localize people in the clinical environment sampling at kind of, do we need such a high frequency? Like, I think their max sampling was like clinic max sampling. Max sampling is like 10 times a second or something like that. And we were like, can we please not do that? We were imagining our database just filling up with all of this high sampling rate. And we tested it and we found that the twice per second was completely sufficient. And so that's what we went with in programming the machines. So this graph is showing the results of an experiment of just trying to see what would happen when we initially set this up in the clinic. Could we capture data for both a patient and a provider simultaneously? So we just did 5 trials of 1 minute duration each, and we saw that most of the time you could separate both the clinician, the blue dots from the red dots, and they were both co-located correctly the majority of the time. There are sources of error in this data capture system. So one of the biggest sources of error is that we have a slit lamp. That is, I don't know, who's been to the ophthalmologist or the eye doctor? Anybody? Okay, oh good, so many people have. So you know that we use this like humongous metal microscope to look at your eyes. So metal interferes with RFID signal. So that is unfortunate. When we did the experiment to bring the slit lamp in front of the patient, we found that during that time, we're not going to be picking up very strong signals. So there are going to be sources of error in the clinical environment that are going to impact our ability to capture data. That's okay, because it's not the whole time. That was about 20, the person is going to be in the exam room for sufficient time that we hopefully will capture their presence even with these sources of error. So, next thing is, we actually had to roll this out, implement it, and get people to participate. And so that's where the CHEPS glaucoma team came into play. They are in charge, they have been in charge of making sure we got excitement in clinic to hand tags out and make sure patients are coming in. They've been in charge of making sure that our data quality is reasonable so that we know that when we try and do analysis, we're not just getting garbage data. So we've been following the percent of patients recruited for time studies. We had a very good about 7-month window of where everything was working perfectly. And we had probably about a 25 to 30% patient engagement rate, and it did differ by day of the week. And one of the things that we noticed is that when clinic got more busy, people were not handing out tags. So that's a really important source of bias in our data collection, because we probably are underestimating the wait times, because we really got data more from times when clinic is not busy. Not great, but true. So then we also made sure every week when we looked at the quality of the data coming in, we wanted to make sure that the number of pings per reader per day seemed reasonable. So like on Thursday, you see a dip in both exam room 2 and exam room 4 right here. So that's actually good, because that probably means that people were not in clinic that day. So then we would kind of corroborate it and make sure that our RFID machines were picking up things that were actually true. Oops, that wasn't it. We're not done yet. I know we'd like to be, but we're not quite there. Okay. So then we wanted to see, was our RFID data accurate? So we had, CHEP students shadowed 34 patients wearing RFID tags for about 3,500 minutes. And we found that the match between the raw data and the shadow data was about 65%, and we said, you know what, that's not good enough to really do any analysis with. We need more accurate data. So we engaged a biostatistician from the university, from the CSCAR, the Center for Statistical something or other, but he's excellent. And he said, this is a perfect problem for a hidden Markov model. Has anyone heard of this before? Okay, some people. So I am not an expert in hidden Markov modeling, but what I understand of it is that it basically helps give probability weights people into being in different states. So one of the things that helped within our model is we have a lot of crosstalk. It's sometimes hard to tell if you're in exam room 3 or in exam room 4, because you're right next, the 2 exam rooms and 2 readers are right next to each other. But we know that there's no patient who's running back and forth between exam room 3 and exam room 4 every minute. Like, that makes no sense. So what he did is he said, you have like a 50-to-1 probability of not moving once you're in the exam room. And once he started instituting these kind of probability weights, our accuracy went up to 80%. So we said, okay, now we're getting somewhere. So we kind of went through and tried to figure out where our modeling might be off. But essentially, we were pretty pleased now that our data capture system was working, and we could estimate wait times. So for new patients, we had 187 observations, and we found that they were waiting for about 55 minutes, plus or minus 33 minutes. For return visits, they had slightly less wait time, but the standard deviation is still pretty wide. But you'll see that people are generally waiting about an hour plus or minus half an hour, which is still a lot of time. Then we broke it down by process times. Process times are basically defined as when is the patient in the room with a given provider. And they differ by whether or not you're a new patient, if you're a return visit, if you're a post-operative visit, if you're a visual field visit. Those are all different based on what the patient needs. So then we get to the exciting part where Junhong is making a simulation model for us. So he's using all of this data to simulate what clinic is like in a pretend environment, so that if we were to make a change, we could do it in his simulation model first, see what the impact would be on patient wait times, patient volume, and process times before we would kind of suggest a change in clinic. So we have to also, so in his simulation model, he also took into account the fact that we share a check-in with the retina clinic. So there's not just one set of patients using the resource to check in, there's 2 sets of patients using the resource to check in. We know that we have 5 technicians. We have 3 people doing visual fields. We have people who need to go and get photographs taken at an like down the hallway where we don't have RFID machines. So he tried to he simulated how people would go through a clinic visit, and he used the number of return visits, new patient visits, visual field visits, post-operative visits that we have on the schedule for each day for each provider in the clinic to come up with the model. So then we want to know, does the simulation model wait time by visit type compare to what we got from the RFID? And what we found was the simulation model was kind of overestimating the wait times compared to RFID. But then we thought to ourselves, interesting, maybe it's not actually wrong, because in the simulation model, we were not taking into account that about 20 to 30% of patients were no-showing in our clinic. So if you have 20 to 30% less patients than you thought you would have on the schedule, this is a simulation based on the scheduled patients. This is RFID data collected on days of the week where people are less busy, so when there's less patients in clinic, and then also not all the patients actually come, so there is a discrepancy, but it's not so far off. So it's telling us that for a return visit, the mean wait time in the simulation was 60 minutes, and we're getting, in our RFID data, about 42 minutes. So it's always a little higher in the simulation than it is in the RFID data, but I think we see some reasons why that might be true. So the next thing that we wanted to do with this is actually make it into a live system. So HITS was kind enough to make this into a dashboard so that it could actually be used, because we have real-time continuous data capture. So why not use it to help make clinical decisions about how to service people in the clinic? So a glimpse, as you know, is a momentary or partial view, and that is what they decided to call this interface. So we have this live dashboard now to help us manage operations for the glaucoma clinic. And what they did was they made, so this is the map of our clinic, and you can see they actually labeled people because they're wearing tags. And my tag has my UMID number, and it's in an Excel spreadsheet. It tells me that 0251700 is me. So it can be up here and it can say, hey, Dr. Newman-Casey or Dr. Lichter is in this exam room. Dr. Weiser's here, Dr. Roy's here. Here's the fellow, here are where the technicians are, here's a resident, and here's a patient who doesn't have a name or a label, but has a circle that's getting bigger and bigger and bigger the longer they've been in clinic. So this became a way to help visualize what was going on in clinic in real time. The next step for this will be putting a report up there every week. We basically, of how wait times were last week, and then how were wait times the week before, and what is our trend over time, so that all of the staff in the clinic can see in somewhat real time what impact their clinical decisions are having on people's experience and people's wait time. So we don't have, the wait time is a retrospective calculation. So we don't have the wait time number in real time, because wait time is defined as time when the provider is not with the patient. But the location data and the number of minutes someone has spent in clinic is completely available for people to see in real time. And then we'll be able to add those reports on secondarily, so people can see how they're doing as we make changes in our clinic procedures. We made one change in the middle of our data capture last time, where we changed the way that people get their glasses checked. So if people's glasses seem stable, like the technician measures their vision with their glasses on, and they measure okay, we don't recheck their glasses before testing their field of vision test, which is something that we had done for years and years and years. And when we made that change and we were able to measure it, we found that we shaved off 3.5 minutes on average from every single workup for the technicians. and we enabled more patients to come through clinic without increasing patient wait times. So we basically showed that it's very helpful to have a continuous data capture system in place, and that can really inform, because we didn't know, would we just be taking away a service from patients that they liked, getting their glasses checked more frequently, without actually benefiting clinic, because the bottleneck wasn't with the technicians, it was with the physicians? Like, who knows? So I think it's hard to know. We make a lot of assumptions. It's hard to know without some numbers. So that is, so thank you. Thank you for listening. Thank you for the collaboration. Thank you for your help. I gotta give a shout out to Trevor, who's the team lead. Michelle, who's been doing lots of awesome reporting. And that is in Beth for coming from Kellogg to watch the presentation. And then I gotta thank my family for putting up. So can I have any questions? Happy to. Yes.
Well, basically, you assume that your staffing is correct.
Well,
mean,
I don't know
you
if we
have
assume
a
that.
limited number of techniques, so since you have all this data, can you determine if you should have 8 technicians instead of 4?
Yes, absolutely. I think that's a
So if you look
good
at the
idea.
waiting line in front of the technicians, then you can cut it down by changing the staff.
Right, so I think changing staffing, so there's a fixed number of rooms, but there's not a fixed number of staff. So one of the issues that has come up in the clinical operations meeting is asking if we added a technician, what would happen? So I think that's something that we would definitely like to explore in the simulation model, absolutely.
Yeah,
For sure.
standard procedure.
Yeah, that's where all of the operations engineers are very helpful.
Thank you.
Yes.
Why didn't you modify the simulation model to account for the no-shows?
Oh, we're going to. Thank you. That's the next step is to, I think, Amy was teaching me that you have to assign probability weights to people about how much they have a probability of no showing, which is about 25 to 30%, and that you can do that to each person. And you'll probably get a better estimate of wait times. I think we still have an underestimate on the RFID system of overall wait time, but I'd like to see the numbers coming closer together. Yeah.
So you mentioned that you have kind of a lot of overhead in your databases, and you have your databases are getting full, and you have to archive everything. Are you storing the individual timestamps, or are you storing the intervals that you're saying? I was thinking that kind of sounded pretty reasonable. That instead of actually storing every single timestamp, intermediately, before you enter the database, you have an interval of where the provider or the patient is. And so then you update it with the beginning and end timestamp of when they're in the room, so you're not putting too much data into the database that you're doing the same thing later.
That's really interesting. He talked a lot about this a couple years ago. I think one of the reasons that we chose to archive all the pain data, though I think that it makes sense to try and have way less data in the database because it's really kind of crazy, was because where the provider and the patient are in Kingland is not necessarily true. So we've had to do this kind of post hoc analysis to the pain data to assign probabilities of what is truth for each minute that a person, but I wonder, you're saying could we just collect and it's had to do with summing the decibels over the 1 minute period, looking at the read count and decibel strength from the reader over each minute to see how it compares to the rooms next door, to kind of assign which room the person is in. So we've been hesitant to chuck all of that data. That's how we built the HMM model, basically. But I mean, I wish there was a better, some kind of marriage of more efficient data capture in ways. So yes, if you have better ideas, maybe you should ask for me.
When you mentioned that, I thought about it. Then you brought up the being unsure of what room they're in. I was like, oh, that makes sense. That's probably
Why
why.
we didn't throw it out, but
Yeah,
no, I
makes
wish
sense.
there was a way that we could capture less data. The only way that we came up with to capture less data so far was to decrease the sampling rate. But, and the pins are pretty small,
Yeah.
so we can, yeah.
Well, to that, I was thinking about the same thing, but if I understand you right, you're looking at the dB changed and you're making range determinations, right? Say it's in exam room A versus B, which is next door, is that how you're doing it?
Yeah, that's the first step.
And there's a reader in each room now.
Yeah.
Now, have you thought about making a Faraday cage out of each room?
What cage?
Shield the rooms, so that you'll
Mean
get
with
no
metal.
crosstalk between.
Oh, yes, we've had so many
So we have
talks about.
posters, you know, like the cat hanging upside down, I remember posters to cover the tin
Yes.
foil to cover some of the spots.
So, yes,
No, that's what I was wondering.
yes,
Because there are, I don't know, I mean, two other questions, I don't know what they do, but for instance, I know that in the military, in certain special ops training things where they'll do room takedowns and stuff where they're going after bad guys, they map everybody as they come through, they're not wearing intrusive gear, so they can really debrief what's the best way to, enter a room, where's everybody, and I'm not sure of how they deal with it. You might have a case, maybe they shield or maybe they don't, I don't know. I was gonna ask though, since you can also track individually each technician
right.
or physician, care provider, whatever, do you also then try to look, and if certain technicians have a range of services or maneuvers that they engage in, have you, I guess you could, but have you looked at and say, suppose we see technician A and their mean time with the patient is 15 minutes to do whatever, right, to do tonometry or whatever, and somebody else is always 20, and start looking and say, we have big inter-individual variation. Is it because we haven't really optimized what people do in their tasks? There's some people that are inefficient because of the way in which they, you understand what I'm saying?
So I
Usually
completely
accepting what they do,
understand
assuming they're optimized, and they probably aren't.
what you're saying, and I have very purposefully not done that. And the reason I have extremely purposefully not done that is because people are already so concerned about being timed
Oh, I get that.
that I had that I basically presented this to the faculty and to all the clinic staff as something that we were going to work on together at looking at systems-based improvements and trying not to blame people, individuals in any case. I think, this could easily go down that path, and we could easily find that Dr. Newman-Casey is clearly not as efficient as Dr. Stein, she's, taking way too long with her new patient visits. But I just was hesitant to, from a just functional kind of organization perspective, I was very hesitant to use the data in that way, so I've been aggregating everything and reporting it in an aggregated fashion, pretty much on purpose. Yes, but yes, it exists, absolutely.
Has the glove system been used across other departments in machine medicine?
Well, they made it for us, so that was very nice. They have something similar in the emergency department, but the data feed is not the same. So they had to make this using our database and our data feed, so this was custom made, but the concept, so I agree that it would be very cool if everybody had it, but the problem is that you'd have to have the data capture infrastructure to feed into the system. So then people have talked about, well, can't you just use the electronic health record to extract this data, right? We're accumulating so much data, why don't you just use the EHR? And there's wonderful data in the EHR, and we are using a couple of the variables in the EHR to kind of help our modeling, and that's check-in time and check-out time. However, there are many other timestamps, and then we also looked at audit logs, which is when providers are in using a workstation that can be linked to a specific exam room, and when they're in a particular patient's encounter to make sure that our data capture from RFID is fine, and it is, but it's very hard to capture wait times, so you can capture encounter time to some degree, like the amount of time I'm sitting with you with computers on and I logged into your chart. What we can't capture is how long you were sitting in the room waiting for me before that happened. So because we wanted to capture wait times and because we wanted to focus on this kind of patient-centered thing, which is valuing your time and if you're in our clinic, providing you with services while you're there, that is why we kind of went to great lengths to get more granular data capture, and that's what's feeding into that interface. So yes. Yes.
So are you, I know you just said you're looking at wait times, but have you looked at why some visits may be longer, actual visits with a provider may be longer than others? Because I think of colonoscopies as 30-minute procedures, but if you get a patient who has a bunch of polyps, it turns into an hour-long procedure, which has downstream effects. So I was wondering,
So number one, would you like to join the CHEPS Glaucoma team? So number two, so yes, that the team is very interested in looking at that data. So we've been working really hard on getting high quality data so that we can then answer some of those questions. So that's why we've been having this continuous data pull. We have an automated data dump that every single person who has a tag, we get all of their visit information so that we can look at things like that. Like, a really reasonable question is, does it take longer for somebody who has more severe disease? Does it take longer for somebody who has worse vision? Should we be kind of scheduling those appointments differently? Like, if somebody's 96 years old and has to do 3 tests and has really severe disease and poor vision, should we not assume their appointment's gonna take 15 minutes? I couldn't agree with you more. So that's why we've been pulling all that data, and hopefully now that we have good RFID data, we should be able to analyze some of that. Really fun.
Did you do any benchmarkings of similar systems in other hospitals or settings like that?
So, benchmarking is a big word. I was just doing research. So the only system that I've seen like this is in Virginia Mason. Their whole hospital is basically like this. And I think their hospital has invested in really high-tech infrastructure, and not like the students don't maintain it. So I think, could we move in that direction? That would be like a clinical operations issue. This was more of a research project. There has been research into this. There hasn't been that much published on it. I think it's because a lot of people get stuck at the hardware stage. We were very lucky to have a lot of good team members who've gotten us over a lot of hurdles. So a lot of people got stuck at and then people will get stuck basically if you read the literature on the data analysis, because if they looked at the raw data compared to the observation data, and it was only 60% accurate, and that's not cool. That is not going to be helpful in terms of optimizing schedules, right? Like, we had to get to that 80% threshold for me to start feeling like I believed in the data. So it took a lot of just different kind of layers of expertise to get there.
So the patients are in a room all the time. Where does the patient go when they're waiting?
Yeah, so that's another issue. Patients wait in multiple places. So the patient comes and waits in the outside waiting room, and then they're called back to an exam room by a technician. They then see the technician, and after they're dilated, or after the technician finishes their portion of the exam, they move to a place that we call the in-process waiting, which is another space where we have RFID readers, but the RFID readers, just the physical space is not as amenable to collecting signal, good signal. So that was interesting. And then they are brought back, they either go to photography or they get brought back to an exam room or they go to a visual field room. So they're waiting in multiple places in the clinic. I think this is this is different than a primary care doctor visit, but it's very similar to a lot of the specialty clinic visits where you have to have multiple steps before the physician sees you, and it's in multiple spaces. So that was one of the challenges. So another reason we didn't use the EHR data, the electronic health record data, is because, for example, there's no electronic health record data that comes when people are in their testing. And so it's like you're missing large chunks. All right. Am I going over? Because I don't want to keep you past your time. Okay. You guys asked wonderful questions. Thank you very much. Is there more questions? Yeah.
I was just wondering if there's other things you want to track with people, equipment, or...
Yeah, wouldn't that be fun? So, yes, I think the hospital already has an active RFID system for some of its huge pieces of equipment in the main hospital. So that's a different, basically, like engineering problem, because things are very small. And to accurately locate very small things, you need like very good GPS, and you sometimes need to use active RFID So we did think about, so we have one instrument in our clinic that everyone needs to use called a pachymeter to measure corneal thickness, and every new patient needs their pachymetry measured, but we have one instrument. So we thought about, what if we tagged the pachymeter, and could we just see in real time where that thing is, because we're always knocking on people's doors. Do you have the pachymeter? Oh, where'd you put the pachymeter? So yes, I think that it could have many applications.
I think anesthesia actually does it with the portable ultrasounds for doing blocks throughout the hospital. They can find them in a lot of places because they were worried about them being left around.
Right.
So they can run them down. I believe they've tagged all theirs and they find them that way as they migrate around the hospital.
Yeah, and I think that active RFID where you have like a much larger range, so you saw the passive RFID really only works up to 20 meters, and the active RFID works much farther, and I think that's why they chose to use active RFID for things, because in the hospital, and
Yeah, I'm not sure. I don't know
anywhere.
the technology used, but it's not.
I think it is Stanley, yeah. Anyways, okay,
Thank you.
thank you.